morning. Welcome to the Tuesday, November 7th edition of the Board of County Commissioners regular board meeting. And to those of you who were present for our meeting last night, welcome back. Good morning, Ms. Morker-Heisky.
Morning.
Do we have any adjustments to this morning's agenda?
No.
To the board? I see none. Then I'll ask for any emergency business.
No, none.
To the board? I see no emergency business. So before we move into our Health and Human Services meeting, we're going to have a few moments to recognize veterans and recognize the fact that Saturday is Veterans Day. Every year on November 11th, we celebrate and we recognize those among us who have served in either the armed forces or other branches of the military, and people who have been a integral part of making certain that we are able to live in relative safety and relative comfort in these United States. We have I'm going to ask, I believe Joby Riley is going to step forward. Joby Riley is our Veterans Services Officer. He's also the lead Veterans Service Officer for the state of Oregon, has been for a number of years. He's also an Arsenal fan, but we don't hold that against him. Joby.
Thank you, Chair Farr, Vice Chair Trieger, County Commissioners. Thank you for inviting me today. So I've been asked to present some kind of demographic and basic information about the veterans in our community. And so I'll start off with that. The Federal Department of Veterans Affairs does a population estimate every few years based on their actuarial tables, utilization of their benefits, coordinating with Department of Defense regarding those who have been discharged to various communities. So based on that information, their current estimate as of September 30th, 2023, is that there's 27,320 veterans in Lane County. The fastest growing population of veterans is women who have served, and there's currently 2,588 women veterans in Lane County. But the most striking bit about the veteran population, I believe, is the aging of that population. The largest cohort of the veteran population is the Vietnam era veteran. So veterans who are 65 to 84 years old, 12,010 in Lane County, and veterans over 85, 2,192. And so over the years, the total veteran population has been diminishing. However, the age of veterans is higher than it's ever been, the average age of the total veterans in Oregon and Lane County. And so that really creates increased needs for services for county veteran service offices. What county veteran service offices do at its heart is, first of all, we are our community's recognition of the service and sacrifices of our veterans. And so our mission is to basically translate what the VA tells folks. So if a veteran called up the VA and said, hey, send me information about my VA benefits, what I might be entitled to, they would send them this little booklet. The National Veteran Legal Services Program, however, publishes this booklet, or treatise, I guess I should call it, the Veterans Benefits Manual. This analyzes the statutes, regulations, and case law that govern VA benefits and the procedures by which VA adjudicates eligibility. And this is the information that county veteran service officers are trained on, we must test on in order to become accredited. And so our mission is to help bridge the gap between what VA may tell folks they might be entitled to and then what folks actually need to do to get those benefits. Those benefits, well, our mission is not just altruistic. It's not just to recognize the service of our veterans, but to ensure that they're receiving the benefits that they've earned to help support our local communities, especially when the benefits are based on impacts they have that impair their earning capacity. So last federal fiscal year, so that's 2022, direct benefit payments to Lane County residents was over $200 million, $203.6 million. And this is the largest amount for any county in Oregon. Multnomah County receives $171.4 million, Washington County $173 million. So even though both those counties have higher veteran populations than Lane County, we receive the highest total benefit disbursements to our residents. The Lane County Veteran Service Office can't take sole credit for that. We represent the majority of veterans filing for benefits in the county, but really that amount of benefits is based on the great amount of support in our community for veterans. That entails the Department of Veterans Affairs health workers who are treating our veterans, documenting their issues so that the benefit side of the house can see their impacts. It includes organizations like Easter Seals, Goodwill, St. Vincent de Paul, who have grants from the VA and provide many homeless veteran services, employment services. All of us work together as a network to ensure our veterans are aware of their benefits and are able to access those benefits. I was also asked to talk about some of the challenges that our veterans face. And in many ways, those challenges are the same as all the members of our community. High cost of living and housing, difficulty in accessing health care, and finding employment that they find fulfilling and is sufficient to support their family. And while I hesitate to generalize the experience of all veterans because it is quite a broad population, folks from all walks of life serve our nation, one of the things that struck me over the years that I've been doing this work is the impact that military service has on those who have completed their service. It is one of the most foundational periods of all of our veterans' lives. Whenever one may have served, whether it was in the jungles of Vietnam, the deserts of Iraq, or in Kansas in 1987, that period of service really lays the foundation for the person that young person will be for the rest of their life. One thing that has always stuck with me is one of the prior directors of Health and Human Services, Rob Rockstraw, was a Vietnam veteran. And during a budget presentation, there was kind of just a generic slide of a veteran wearing the medals that they had earned during their service. And Rob ended up tearing up and actually crying in front of the budget committee. He was somebody that seemed to have processed his combat experiences quite well, was obviously doing very well in the world, professional county department director, but still the strength of that experience, the nature of that experience had impacted him for the rest of his life and really formed who he was. And I think that's consistent through it for all our veterans. And so that loss of community, that loss of mission and purpose that folks have during their military service, I think that's one of the biggest hurdles that our veterans have in transitioning to their civilian life. Some counties have dedicated outreach workers to help ensure that we're spreading the word about their benefits and helping to create community among our veterans. We don't have that in Lane County. We don't have a specific position, but we try to fill that role with me doing outreach to various community organizations with our staff, going to U of O and reaching out to the student veterans, and really helping to be a place where veterans can come to us, can contact us, and while we might not be the primary provider of the service they're looking for, make sure that they find who is that organization that can help them with their needs. We also are trying to ensure that everyone who wore our nation's uniform is treated with the respect that they've earned. And so historically, women who have served, LGBTQ veterans, service members, those from historically discriminated communities, we are trying to reach out to them specifically to ensure that they're aware that they are entitled to benefits as well. Many women veterans historically have not felt that they were veterans because they didn't serve in combat. They weren't allowed to do that. Many LGBTQ veterans were discriminated against in their service, received less than honorable discharges. That now is not the case, and we can help them upgrade those discharges. But our mission really is to ensure that everyone who wore our nation's uniform and did so honorably is able to access their benefits, and we're here to help them do that. But we could not do that without the support of this board and the Budget Committee, and so it is, anything that we're able to accomplish is really based on your support, and so thank you very much.
Thank you, Mr. Riley. Then I'm going to take this moment in time to ask anyone in the audience today who is a veteran or a family member of an active veteran to please stand up and be recognized. And I'm going to ask at this moment if Lieutenant Rich Glessner would step forward for the Sheriff's Department. Today, we have asked members of the Sheriff's Department to be with us. The Sheriff's Department has a large number of veterans, and today, Lieutenant Glessner, can you introduce the chief and the two captain and lieutenant? Thanks.
Sure. We have the Chief Deputy, Carl Wilkerson, our Captain, DJ Mann, and Lieutenant Ryan Wells with us as well. So I was asked to come up here and just represent the veterans of the Sheriff's Office. We currently have more than 50 veterans of all branches of service serving with the Sheriff's Office. We've all been very proud to serve our country, and now we're equally proud to serve the citizens of Lane County. So thank you very much for the recognition. It means a lot to us.
Thank you, Lieutenant. And also note that Lieutenant Ryan Wells stood up as a former veteran. Lieutenant Wells, thank you for being here with us today. I'm going to take this moment to ask the Board of Commissioners any response they'd like to provide. I'll say this before we get into that is in 2015, we recognized that there were a large number of homeless veterans in our community. So on this date, on November 11th, 2015, we launched Operation 365 to house homeless veterans. And over the course of the next year, we housed over 404 veteran families who had formerly been homeless. Now, Commissioner Buck wasn't a commissioner at the time, but Commissioner Buck was in doing a lot of real estate transactions, particularly working with St. Vincent de Paul at the time, and was an integral part of housing those 404 veterans in that one year. And since then, I think the number has exceeded 404 more veterans beyond that. But it was an initiative that we undertook, and Joby, you were a large part of that. We housed a lot of veterans in that year. So to the board, any comments or comments or questions? Yeah, Commissioner, excuse me, I'm all choked up. Commissioner Senega.
Yeah, I just want to take a minute to express my gratitude for all those who have served and their spouses. Veterans Day is your day, and as free Americans, we are honored to be able to celebrate that day with you. I encourage everybody that is here in attendance and listening to attend one of the many events in or around Lane County. We're very lucky just down the road in Albany to have the largest Veterans Day parade Saturday this side of the Mississippi. I know my family and I will be there. We've gone for years, and it's a great tradition.
Ride the roundabout afterwards.
Yes.
Lieutenant, excuse me.
I've been promoted all of a sudden from NCO to a lieutenant.
Commissioner Lovell, then Commissioner Buck.
Thank you. You know, Veterans Day is the Saturday, November 11th. It's the 11th day, the 11th month, the 11th hour. It was selected after World War I to be the proclamation of Armistice Day. Since then, since 1978, Gerald Ford made it Veterans Day to honor all veterans. So we're celebrating that with you all that had served and the families that had served with you. To honor the veterans, though, also the National Association of Counties is doing a green light proclamation. Green light, which honors the veterans. It's going to be shining from your porch or the halls of government from the November 6th through the 12th. And so I urge you to go out and get a green light. They're LED, so they won't cost you hardly anything to run. They may cost you a little bit to buy at Jerry's. Jerry's is a good place to buy these. So you can put that on your porch and honor our veterans in a very visual way that the National Association of Counties is doing a proclamation. So I want to also say there's about 200,000 vets that transition every year from the United States into civilian life. And by shining this green light, you give them the hope that their service and sacrifice was appreciated and that they're being watched and supported by the citizens of our counties and the citizens of our towns that support them like we have today. And so today, I want to give this green light to someone who'd served honorably in the Army, who is also a person that had came over and immigrated into the United States and has been a great leader and a mentor of mine. I want to give this to our Chair, Pat Farr, and to thank him for his service, not only as a veteran, but as an honorable citizen of our community. So here you go, Pat. We salute you.
Thank you. Commissioner Buck.
I did not know that green light was a thing. That's good to know.
It's a good thing.
As a spouse of somebody who serves, I just want to recognize the family members that serve alongside. I know what it's like to be separated from your spouse, and that separation for your children as well is palpable, and it's not an easy life. And sometimes when service members return, they can be very different people. So I want to thank them for sticking in there as well, and for their service as well. Thank you, Chair.
Thank you for that, Commissioner Buck. And you represent a large cross-section of our population who don't actually wear the uniform or step into the uniform, but you do bear the burden of those who do, because you spend a great deal of time basically as a single mom while your husband is a C. So, thank you. Vice Chair Trieger.
Thank you, Chair. Thank you, Joey, for the presentation and the information. I'd love to have those numbers. If you could just shoot them to us in an email, that would be great. Thank you. And thank you for bringing up Rob Rockstro, who was a real incredible contributor to many initiatives in this community, but particularly to mention the impact of his service had on him many, many years later. My father was a World War II veteran, served as a communications specialist, backing up front lines during World War II in France and Morocco and in Italy, including on the rather infamous Anzio beachhead. And his father before him was a cavalryman in the Polish army in World War I before immigrating here to the United States. And this Sunday would be my father's 99th birthday. He's long gone, but so his birthday is always right adjacent to Veterans Day, and so I think of him often. I actually have his dog tags. So thank you for mentioning the impact way after service. My father, in fact, wrestled with that. I think we now have a name for it. We didn't know what PTSD was by name when he was experiencing those things, but one of the ways that he reconciled with what he did in his service was became a very active member of the National Organization of Veterans for Peace and did a lot of work supporting other vets in reconciling what they did as the right thing at the time, but then later had a hard time comporting that with where they were in the world. So I really appreciate so much you bringing this information to us today and elevating the voice of folks in our community. And thank you for doing all the good work that you do here.
Chair.
Thank you, Vice Chair.
I've had the honor to see some World War I discharge documents, and everyone was rated on their horsemanship back then, and also their complexion was always ruddy.
Well, I'll remind everybody that Tom Egan, whose name we recognize from the centers here in town, the Egan Warming Centers, was a cavalry officer. His face was always ruddy, and I served with Tom Egan. I served in the 7th Division in the 2nd of the 162 here in town in the Oregon Army National Guard, and we were light infantry. 7th Division was stationed at Fort Ord after Vietnam. I was a post-Vietnam member of the service. But, you know, our parents were a part of most of our parents were a part of what we call the Great Generation, the ones who endured what was a world war, and a global war that affected virtually every corner of the entire globe. And Vice Chair Trieger, for you to bring that up about Anzio, I did not know that. That was a pretty horrendous operation. Well, with that, Joby, thank you very much for being here, and thank you everyone for helping us celebrate Veterans Day and recognize those among us who have and do serve.
Thank you. I appreciate the opportunity. And Chair Farr, if I may approach, I do have a printout of some of the data I've provided.
Thank you.
Thank you.
Blades. And Ms. Mokrowski, we'll move it on to our agenda, and if, in looking at our agenda, those who have looked at it notice we do have a 9 o'clock time certain with as a Board of Health. I'm going to, in a moment, I'm going to recess the Board of Commissioners and reconvene in a joint meeting of the Board of Commissioners and Board of Health, and mention those who are here for public testimony. Public testimony will follow our 9 o'clock time certain, which is a report on the Board of Health. So, at this point, I will recess the Board of County Commissioners and reconvene as joint session of the Board of County Commissioners and the Board of Health. And Ms. Mokrowski, I'll take a second to introduce Director Gray and ask Director Gray to introduce the panel, if you would, please.
Good morning. It is my pleasure this morning to introduce two members of our public health team. Dr. Pat Lugke, who is our public health officer, also a Lane County veteran, will be speaking for much of the presentation, but we will have Ms. Rachel Stenson kick it off, who is one of our program managers over a number of areas, including communicable diseases and mobile outreach and a number of other public health programs. This is our most complex division in terms of the number of programs. So I will turn it over to you, Rachel.
Thank you. Good morning, Commissioners. For those of you who I have not had the pleasure of meeting, my name is Rachel Stinson. I'm the Health Protection Unit Manager at Lane County Public Health. We are kind of a complicated structure, and my name doesn't tell you much about my title. So within my unit is Environmental Health, Public Health Emergency Preparedness, Mobile Public Health, our Public Health Reserve Corps, and Communicable Disease, which is why I'm here with you today. So I just wanted to very briefly update you on the COVID vaccine supply issues that's facing our community right now before handing it over to Dr. Lugke for a different presentation. Trying to get vaccinated against COVID has been a source of frustration for many members of our community. And so the current status is true that there is a shortage of vaccine supply. This is not just a local phenomenon. It is across the state, across the country. The exact reasons are not explicitly clear. However, there is a very big difference in this year of previous years in that the process is completely privatized. So, of course, in previous years, we had federal, state, and local emergency responses that were driving the logistics of distribution and administration of vaccine. And that is not the case this year. It is, again, completely privatized. So here at Lane County Public Health, we do not even have vaccine supply for the general public, should we still have dozens of vaccinators on staff. Our delay in being able to administer any vaccine was really due to, unfortunately, the state being under a very tight timeline in being able to provide us both with COVID vaccine supply and funding to be able to administer the limited vaccine supply that we will be able to provide. And they have been working very diligently on it, and we have just recently started getting supply and funding for those services. So that brings me to what we are actually doing here at Lane County Public Health Communicable Diseases. So we are administering COVID vaccination in the same way that we administer our other vaccinations as a safety net organization. So, of course, during a national emergency, we are a safety net for the entire community. But now we return to our more traditional role, and that is providing safety net vaccines for those who have a lot of barriers in being vaccinated. So we do have supply for providing vaccine through our Vaccine for Children program and for providing vaccine to adults who are underinsured or uninsured. We are focusing all of our efforts in reaching those who face barriers to vaccination, even going to those who cannot come to us. So, of course, we are vaccinating children. Some other populations would be the unhoused, BIPOC people, refugees, to name a few examples of who we have vaccine supply to provide for. We do encourage anyone with health insurance that covers vaccination to seek vaccination, COVID-19 and otherwise, through their healthcare providers and their pharmacies. Those are entities that will be having supply for them. We recognize that it is frustrating to find those. People are calling a bunch of resources and hearing that there's not availability. We have seen locally that some of the supply is self-correcting, and I'm optimistic that it'll continue to do so. The future of COVID vaccination and our role in that is unclear. Our role is very much determined by, again, vaccine supply and funding that is available to us. And our state and federal partners are really focused on trying to get through the situation that's in front of us this vaccination season. And so we don't have a lot of details for the future. All of the indicators that we've been given is that they are trying to make this year repeatable year over year. And so we will be able to include COVID-19 vaccination ongoing. And I'm very hopeful that that will be the case. I know this is a very brief update, but it has been a source of a lot of frustration in our community. We're hearing a lot about it in communicable disease, and our role in this situation has changed drastically from what the community is used to in the last 3 years. So I wanted to provide y'all with a kind of situation update on that. I am going to remain on hand in case there's any questions about vaccine supply in the discussion later this morning. But then I'm going to hand it over to Dr. Ludke for a related but very different presentation. Thank you.
Thank you, Rachel.
Thank you, Rachel.
Chair Farr, Vice Chair Trieger, thank you for the opportunity to join you today. Can we pull up the slides, or do I do that?
I'm happy to bring them up for you if you would like.
Yes, please.
Thank you, Ms. Jones.
Okay, one moment.
Diana, I got it.
Okay, you don't want me to share?
No, we'll share here.
Okay.
Is there enough to go around?
It's the hardest part of presenting at a board meeting
Deciding who gets to share.
and figuring out how.
Thank you so much. Wonderful. So I thought I would begin with a poem. We're moving into winter, and we're moving into a little bit of uncertainty, but one thing that's certain in this region we live in is rain, and sometimes snow. And this poem, I think, transitions us well into that space. It's by Wallace Stevens. He was a executive with the Hartford Insurance Company, actually a vice president for years, and was a full-time VP, but he wrote poetry all of his life. And he lived in Hartford, Connecticut, and he would walk to work from his home. And he'd walk through these parks that he had basically lived around for many, many years, and would come up with his best thoughts, as he would say, in the morning, walking to work, and sometimes walking home. And this poem is from one of those walks in the wintertime in Hartford, Connecticut. It's called The Snowman. One must have a mind of winter to regard the frost and the boughs of the pine trees crusted with the snow, and have been cold a long time to behold the junipers shagged with ice, the spruces rough in the distant glitter of the January sun, and not to think of any misery in the sound of the wind, in the sound of a few leaves, which is the sound of the land, full of the same wind that is blowing in the same bare place. For the listener who listens in the snow, and nothing himself, beholds nothing that is not there, and the nothing that is. So we're going to talk about the nothing that is not there and the nothing that is. And that is a segue into the pandemic lessons learned and not learned. And we learned a lot of lessons in the pandemic. We had some affirmation of lessons we had learned years before the pandemic. We knew where some of the choke points and challenges would be as we entered this space. But there are lessons, 8 of which that we've pulled out today, that we feel that we've learned part of the lessons, but if a pandemic occurred again within 3 months or a year, we probably still wouldn't be ready. We would still have challenges that we had with the COVID pandemic. So I'm going to dig in with that. And we are not alone in doing this sort of retrospective review. On the left side of your screen, those are 3 different public health organizations that have done really deep dives on lessons learned. In the upper left-hand corner is the World Health Organization. Each of their 6 regions, this particular cut and paste from their website is the European region. We are in the Americas region of the World Health Organization. Did really deep dives and published hundreds of pages of documents of what went well in those 6 international regions and what didn't go so well. Our federal colleagues did the same, the CDC, the FDA. The one in the middle on the left is the FDA assessment of how they did. Here, In Oregon, on the lower left-hand corner, is what the Oregon Health Authority did. They contracted with a group, the Reed Group, well-known here in Oregon, and produced a couple hundred pages of lessons learned through the Oregon Health Authority. Not to be left out, academia, of course, did its thing, a couple of those in the middle. Academia, Yale Medicine was one, and some of our nonprofits and some of the larger think tanks like the Rand Institute and Kinsey, they did the same thing. And these are all available, and we've looked at many of them. But this is what most people do in this space, doing lessons learned, and a hot wash is, one of the terms sometimes is called. Well, the pandemic started March of 2020. Officially, the federal designation ended May 11th, 2023 this year. Hard to believe it was officially ended this year. It seems like 5 years ago already. Many colleagues in the health department talk about BC before COVID. It's sort of true. I mean, COVID kind of warped time. I think Einstein was wrong. It really wasn't gravity, it's COVID that warped time. Anyway, we are following in a line of all these organizations of doing a deeper dive and looking back. And the 8 items that we pulled out to take a deeper dive at are areas where we feel as though not only do we want to share with the board lessons learned, but opportunities to make sure we're better prepared the next time. And we will not pretend to have all the answers in this space. I think we have more questions than answers, but I want to share some of the experiences during this time. So the first is personal protective equipment. If you could transport yourself back to March, April, May of 2020, did you have enough masks for your business, for your home? Did you have enough hand sanitizer? We had shortages of that. Gowns and gloves. We had shortages of all of these things. And probably most importantly, we had shortages of those in the hospitals, in the clinical care environment, real challenges. And it's a shame in many ways. This is in some ways a predictable challenge, having a massive pandemic, whether it's flu or coronavirus or whatever it might be. But we were really short. Within just a couple months, we at the health department received phone calls from our hospital colleagues saying that they were going to be running out of gowns and gloves and masks, and what can we, local public health, do to help them? Well, we don't have a repository very big. We have enough to run our operations within HHS, but we were not tasked being the repository for PPE for the entire community of nearly 400,000 people. Fortunately, we had some very intrepid staff, and we went to practices that closed. Many dental practices closed for months. Digging in the mouth is right where the virus is, and they were closed for months. And they were magnanimous enough to share their gowns and gloves and masks and hand sanitizer and such, and we were able to spread those all around. For a time, we tracked the amount of that we were transporting to other practices. When we hit the 100,000th item, we just stopped counting. It didn't seem to make much sense to count anymore. But it was a lot of work, and this was a new job that wasn't part of what our horizon-gazing vision was for the public health role during the pandemic. So the lesson learned in this space is that clinics, businesses, schools are going to look to public health for these key PPE items. The lesson not learned is we still don't have a state-level repository. We still don't have a regional repository. We still don't have a local repository. We don't have a hub to do this work. If H5N1, a particularly nasty influenza virus that's been circulating out there for some time, if it finds a way to easily transmit from person to person, that'll be our next pandemic. I'm not predicting it, but that is an example of a possibility, and we wouldn't have enough PPE within 90 days. It would be very similar to what we endured for the last few years. The next item is parallel to this, this other clinical critical supplies. And I have a few examples, real items that we endured. We had a call from one of our local hospitals, a midnight phone call from an infectious disease doc. If we don't get 2,000 nasopharyngeal swabs, we have to close the hospital to all elective procedures. Now, elective, that word means it's kind of an option. You can do it or not do it. But some elective procedures, like if you need a cardiac bypass, you can't wait forever. If you have severe pain from a hip or a knee, you need a transplant, you can't wait forever. Some of these elective procedures are more elective than others, but the bottom line is you don't want to bring somebody into the hospital with a communicable disease to other people who are frail and fragile in the hospital without testing them and saying they do in fact have COVID, they should go to the COVID ward. You can't do that without swabs. So we had a massive shortage of not just PPE in this country, but other really critical items. We, again, begged, borrowed, and stole from practices that were not open. We tried to get supplies from the federal government. We got some from the state, and did the best that we could. But it was a real challenge. We had a similar call with laboratories. There was a shortage of many of the reagents required to do this COVID testing. And after a short period of time, there were shortages of other reagents to do basic things like chemical panels and blood counts and those sort of things because the supply chains got so messed up. So we became the arbiter, the distributor of laboratory reagents. Again, not a role that we envisioned doing. The university was able to step up and do a lot of COVID testing. We got them their primers and probes and all their molecular reagents. That was our job. So, some really tough stuff. Lessons learned, again, the clinical community is going to turn to us for things we didn't really think they'd turn to us for, like laboratory reagents. That's kind of an interesting thing. Lessons not learned, well, how do we ensure access to these critical supplies? We got lucky in some ways, we were good in some ways in this space, but we still don't have this massive critical pool of things like primers and probes for molecular testing and swabs, these specific reagents for laboratories. And we still don't have that. We haven't figured it out as a locality or as a state. Next item, direct care delivery. This is clinical and non-clinical. And we, as you will recall, we rapidly stood up sites for clinical care on the Lane Event Center, the county fairgrounds. We had the Expo Center for persons who were not sick with COVID, and we had close to 200 people there at any given night for many, many weeks. And as you well know, because we operate a jail, when you have people 24/7, you own them 24/7. So, we had to get them food 3 times a day. We had to make sure they didn't have a flu outbreak when there's 200 people in one room. Lots of things we had to do. We had the persons with COVID across the parking lot at the Wheeler Pavilion, held up to, I believe it was 44 people at any given time. I don't know if we ever got to 44, but we had dozens in there at any given time. And these were people who had COVID. They were stable enough to be released from the hospital, but they couldn't go back to a place where they would not spread it to somebody else. So we owned them and we had them in the Wheeler Pavilion. As you know, we also purchased the old VA clinic. As a vet myself, I hasten to say old. It's a really nice facility. I'm kind of surprised that Uncle Sam gave it up, but we purchased that and repurposed it, used it for a variety of clinical purposes during the COVID timeframe. So lessons learned in this space. We had a lot of existing plans. We have preparedness plans in this space. We have sites where we are going to open facilities if events like this happen, and we could leverage those existing plans, and we did to a pretty good extent. This was a larger conflagration, for lack of a better word, than some of our plans would have allowed us to do. So, purchasing buildings and using contracts with closed hotels and such for clinical care was not something immediately on our radar screen, but we did those sort of things. So we can leverage some of that work. The lessons not learned is we needed a lot of clinical staff to staff these places. And, the health department before COVID, Jocelyn will know exactly how many people we have, 85 people in our public health division, far less than 100. How do you staff up the Expo Center and the Wheeler Pavilion and the VA clinic and the hospitals where I was seeing patients, our nurses were seeing patients? We really struggled in that space. So we have a lot to learn, I think, in that site. It's a lesson clearly not learned. Next, the Public Health Reserve Corps. This is an area where we had a really good sense. We'd done mass vaccination before. I see Commissioner Trieger shaking her head. She was involved in the past. Anyone who remembers 2009, the H1N1 pandemic, thankfully it wasn't as bad as it could have been, but there was a lot of work to do. We're good at mass vax. Can you get better? We can always get better, but we were good at it. We knew it was going to happen. However, this was a large event, and it goes on for a long period of time. This is not like heaven forbid, a terrible plane crash where you have an event and it's over, or hopefully an earthquake that might be really terrible, but you have the worst of it over the course of a few days, not 3 years. So we really struggled, again, getting people to do these mass vaccination clinics because we did not have these vetted staff with the right initials after their name to give vaccines. You can't just pick anybody off the street and say, go give a vaccine. There's infection control, and you have to make sure there's not air bubbles in the needle. You don't want to put air in somebody's arm or get in a vein, and these are real critical problems. So there are a fair number of counties in Oregon that had a medical reserve corps. You may have heard of an MRC. And they were more seamlessly able to transition from no volunteers to a whole bunch of volunteers because they had them all vetted. And the vetting are typical things, looking at their licenses, making sure they have the appropriate license, and then going through HIPAA training and sexual harassment training and substance use training. But that was all vetted beforehand. So we stepped up very quickly and started to create, these coteries, cadres of people to help us in this space. but there's a lot of work, and it would have been nice to have had that all done beforehand. So one of our colleagues, who I think has presented to you before, Sarah Swafford, wrote a grant and got funding for this. It's about 2 years' worth of funding to set up this Public Health Reserve Corps. But when that funding is gone, how are we going to maintain this cadre of people who are ready when the next emergency happens? We haven't figured that out yet. We're lucky to have 2 years of funding, but we don't have general fund for it. I'm not asking for general fund. That's not my job. That's Eve's job. But we do have to figure out, within 24 months or so, what are we going to do for a next step to maintain this capability and capacity? Next up, mobile services. Rachel alluded to mobile services. We, in public health, a long time ago, realized that if you build it, not everybody will come. Not everybody can make it, right? They can't get to your facility. It could be they don't have a car. It could be they have cognitive issues and they can't navigate these, circuitous paths. So we have done a lot of work out in the community. Our WIC program and our home visiting for nurse home visiting and such does a lot of work out in the community, going to Florence and up to Mackenzie. So we were good at it. We were trained at it, but we needed more of it. We needed more people to do this. So we have embarked down the path of discrete mobile services, actually having vehicles and an assigned team and a leader in charge of this. We have to figure out how to afford this, so to speak. For some clinical services, you can obviously bill insurance, but there are some social determinants of health types of services that really you can't bill. How do we fund these sort of services? And going to the people, especially those people, as Rachel was saying, that are not well connected, how do we reach them? Mobile is one of the ways to do it. And we learned a lesson that in the field is a wonderful way to reach people. We just don't have the resources yet to figure out how to make sure it's robust enough for the next time. IT needs, you may think, why did Dr. Ludke put this on the list? You don't control the infectious disease surveillance system that the state creates for all 36 counties. However, you control the staff that work with those systems. And we had just a huge trouble with the system and the staffing to allow us to do case investigation contact tracing for what was an overwhelming number of cases. The system works very well for, 50 salmonella cases in a month. It doesn't work well for 500 COVID cases in one day. The system in terms of staffing doesn't work that well, and the IT system was overwhelmed. And some of our internal pipes within our IT system in the county were overwhelmed sometimes too. So we realized that we need to do better in that space. We have some committees working with the Oregon Health Authority, trying to figure out what to do next. This is a pretty big spend, as you know, in the IT world. You can spend a lot of money really fast, and the state is working on that. But we also need to look at how it is that once the systems are up and running, we can get people trained and we can have so-called a bench, of available people to run these systems when the next challenges occur. Speaking of the staffing side, we had a very interesting and in some ways expansive system to bring people on board. When COVID first hit, the state, from being nudged by the Centers for Disease Control, we're looking at how many case investigators and contact tracers do we need based upon our population. And we needed somewhere between 40 and 80 more people to do case investigation contact tracing based upon the likely number of cases we would have. And as I said, public health is not that big of a program, 80-some people back then. Where are we going to find these volunteers and such? And then how are we going to use their skills, their abilities, train them up, and keep them as long as we can? A challenge that we had in hiring these CITC, case investigation contact tracing people, was we had some rules around the number of hours they could work in this capacity. And typically they would get to their 1,040 hours, which is roughly half-time for a year. And we were required either to bring them on full-time, which we really didn't have funding for, or to let them go and hire on another group. And it was a real loss of the training that we had with the staff. If you think about yourselves learning a new IT system, it takes a while before you learn where to go click next. Then it takes a while to kind of groove your swing, as they say in golf or baseball, to get good enough at it that you're just really facile. And we would bring on these staff, we'd train them into these IT systems, and we'd have them for a couple months, and they'd be doing really good work. And in their last few weeks, they're training the next person coming on, and then we had to let them go. And that's a real challenge. That's a loss of, some real abilities. And in the future, it would be nice if we could figure out what to do in that space during a governor-declared emergency to make it more seamless and keep that talent during a time of great need. And then finally, I don't speak fiscal very well. I joke that I speak only English and Navy. But Zach Evans and Eve really wanted this on here, and I see the genius of it over, I guess, a couple months of having put these slides together, predominantly in August and September. That when we brought on people, that increases the administrative burden. And, you know, there are administrative processes that we follow to keep everybody safe. And whether it's fiscal security or following the union rules for our union contracts or whatever it is, we need to follow these policies and procedures. And we had multiple funding streams coming in from different areas. So the federal government passed the CARES Act, and a lot of money went out, but we had CARES Act money coming directly from CMS, coming from HRSA, which is one of our funders for our FQHC clinics. We had CARES Act money coming to the state of Oregon, then to us. So we had multiple different types of funding streams, and we had to bulk up our financial acumen and our financial staffing to make sure that we followed all the rules. And that was a challenge. And I think the lesson not learned, the increased administrative cost allocations included in these funding agreements, we probably could improve in that space. How do we make sure if this happens again, we're ready? We were pretty quick at bringing on these case investigators and contact tracers, and that seemed to be, you know, the bright, shiny object we really needed to do, but we fell behind in many ways on the financial side. And I think there's still some ongoing challenges in closing out some of those rates and such, because it's a big burden. So I'm going to finish with the reason public health exists. And the Institute of Medicine, 25 years ago now, this year, came up with a variety of documents that public health is to follow in this country, and we've followed them for those 25 years. Of course, the Institute of Medicine has become the National Academies of Medicine. Congress changed their name a few years ago. But the mission of public health is the fulfillment of society's interest in assuring the conditions in which people can be healthy. And that's a direct quote. That's the job of public health. And we did a lot of that during the pandemic. And, you know, we had some failures too, obviously. But this is our North Star, so to speak, moving forward. And these 8 items I shared with you today are items where we're just not ready for the next pandemic. And how is it that we can be better the next time it happens? So I'm going to stop there, and Rachel and I will be more than happy to take questions.
Thank you, Rachel. Thank you, Dr. Ludke, for a very thorough after-action report. You kind of touched on the high points. You could have gone on for quite some time discussing all of the things that did happen. And the first thing I'll recognize is the mass vaccination clinic that took place at the fairgrounds. I participated as a vaccinee, is that the right term? Mm-hmm. And the person who actually vaccinated me was Steve Morkowski's wife, Liz. I'll tell you, it was poetry in motion, watching how those lines flowed and the vaccinations in a very, very safe fashion took place. And it was remarkable how quickly that came together and how smoothly it went. So at this point, I'll look to the board for questions and or comments based upon Dr. Ludke and Ms. Dinson's report. Commissioner Buck.
Thank you. I appreciate knowing the status of where we're at as a county, but I am curious, some of the things that you listed, some the county can do and work on. Some are levels above where we really have jurisdiction over. And although I know that you advocate and you're in spheres where you're discussing things at state and international levels, where do you think we can get up to speed the quickest, and where are other ones that are really long-term systemic issues that must change in order to be able to meet these needs?
That's a good question. I'm happy to not do this alone. I think others up here have opinions in this space. So, you know, the easier ones are the first few that I mentioned. So the PPE, I think our state needs a PPE stockpile. It's very clear that they used to call it the National Pharmaceutical Stockpile. Now it's the Strategic National Stockpile. I'm giving my age here, the SNS. So the federal government is supposed to have a Strategic National Stockpile. We got some of the shipments from the SNS, and we put on the N95 masks, and we pulled the rubber band up, and the rubber band broke because it was in storage for 10 years, and, you know, rubber isn't pliable forever. And it's pretty clear the SNS is not going to be robust enough for A, B, C, or D emergency. So it's going to devolve to the states, and our state hasn't stepped up in that space. So advocacy at your level, through AOC, through organizations that you know better than I. If the state's not going to step up, then what can we do regionally? And for emergency purposes, we are linked Region 3 and Region 5, the emergency regions in Oregon. So the 5 counties, Coos, Curry, Douglas, Lane, Jackson, and Josephine, so 6 counties are Regions 3 and Region 5. And those health departments work together. I know all their health officers. I have them on speed dial, and we talk regularly. And we've talked about what can we do in the space for some kind of regional preparedness. And again, it might not be coronavirus, right? I mean, it might very well be some other agent. It might be chemical terrorism, bioterrorism, but we need to be ready. And how can we do the PPE side on a regional basis? And if we can't do it regionally, well, then it devolves to the county level. So I think that's a first one. We have talked, even I have talked at length about supplies, critical clinical supplies, like the swabs, like laboratory reagents. We have tried through a group that we operate called the Health Roundtable with the CEOs of the largest healthcare groups in our county to get others interested in this. Could we all bump up our supply a little bit? Your burn rate is A, make it
Recording in progress.
Make your burn rate 20% higher, then we each have about 20% more. If there's an emergency, then we have more time before the supply starts to meet the demand. We haven't gotten traction on that yet, unless Eve has an announcement. But that's another area where I think there's an opportunity for local advocacy. In the space of the Public Health Reserve Corps, we really need to have this system ready, whether it's Cascadia earthquake or, like I said, hopefully not bioterrorism, chemical terrorism, or another infectious agent problem. We need to have people available and vetted, and we need that system to continue. And, you know, like I said, we have 24 months of funding, but that's going to be the end of that grant. How do we continue? So I think those are probably the first 3 that show the most promise and probably the shortest window to make a difference that I would recommend. Maybe Eve has other thoughts.
Sure, I'm happy to pepper in. I think that with any kind of a stockpile that we could consider, a public-private partnership is really the best way to go, because all of these supplies expire. And so if we invest public resources in stockpiling equipment that's just going to expire, that becomes wasteful, it becomes resource intensive. And the best way to manage this would be to have a regional or a state, ideally, stockpile, where folks would purchase, private industry would purchase from the stockpile as you're rotating stock, right? And then the stockpile purchases from vendors who are bringing in the brand new equipment. And then you have your rotation of stock. As Dr. Ludke mentioned, we don't yet have our local private sector on board with that conversation about how we could partner in such a way. But really thinking through sustainability, I don't see an alternative option for sustainability unless there's going to be dollars raining from the sky for maintenance of supplies that we are never going to use or would only use in the most catastrophic circumstance, maybe once a decade or more, hopefully. And I think the other thing that I would say that we could do more immediate term is that last slide on our fiscal readiness. We were not ready for the FEMA requirements related to the tracking and documentation of the activities that we were doing in COVID. And we are at terrible
Recording in progress.
In any type of an emergency of losing the ability to be reimbursed for the critical services that we are providing to the community and causing our local taxpayers then to have to pay more of that burden than they should have to. So I think, I know that Mr. Adams, as he is recruiting for the new emergency manager, has this in his mind on how do we assure that we aren't just focused on the shiny thing, as you put it, Dr. Ludke, but we're focused on the fiscal recovery portion from the moment that the disaster starts. How do we have the fiscal folks in our command centers, setting up all of our processes, proactively assuring that codes are in place so that we can transition from the financial perspective into these emergencies as well. To me, that's a lower hanging fruit that we could accomplish locally without a whole lot of other partnerships.
Appreciate that, thank you. I knew some physicians at the time, they were retired, who wanted to help, but they couldn't find the avenue to make it happen. And it was just a loss of great people in our community that, eventually it went through the state, I think, and at the state level, they're still working on something more robust. I don't know how that integrates exactly to what we do here locally for that kind of situation, but I could see how that could be an easier, more manageable thing to do in the short run.
Thank you, Commissioner Buck.
Oh, I would just say that is our Public Health Reserve Corps. And the one thing that we cannot do locally is for providers who are retired, who have expired licenses. That is a state-level decision as the state has declared a level of emergency to reauthorize individuals who have expired licenses. But we will have the Reserve Corps in place. And as Dr. Ludke mentioned, really have to think about sustainable funding for that so that we can create that pool of volunteers so they don't have to go to the state and be deployed somewhere else. They can volunteer locally.
Thank you, Commissioner. And Vice Chair Trieger, before I call on you, I'll recognize that Dr. Jocelyn Warren is also with us, who is our Public Health Director. So, Dr. Warren, anytime you have a comment you wish to step to the mic, please feel free to do so. Vice Chair Trieger.
Thank you, Chair. Thank you for the presentation. Like Commissioner Buck, I was thinking how many of these things really are the OHA's problem to fix that impacts us, or FEMA, or other federal agencies. And I'm sure right there doing their after actions. I know we just got news yesterday of a new OHA director, so remains to be seen what her priorities and how she frames conversations about working with local public health authorities, because I know the allocation formula for vaccine, for example, was a huge challenge because it didn't line up with, it looked at case counts and vulnerability, but it didn't also then line up with readiness. And I know we were one of the most, in spite of all the challenges you named, ready communities to deliver more vaccine than we were then allocated. So how we have those conversations with our state agencies so they understand what our capacity is, so they help us work to the very top end of that, but also help us solve the problems for the gaps. So I'm wondering what you're hearing from OHA and from our federal partners on progress toward addressing some of these issues. And particularly, I'm very curious about if anybody's had any conversations about modeling on the old war production boards, sort of an emergency response production board, where you take manufacturing facilities or folks who are making one product and pivot quickly. I know that happened on a very micro scale, for instance, with some of our distilleries, our artisan distilleries quickly pivoting to producing hand sanitizer. But there are all kinds of production facilities that are making equipment and supplies. Has there been any discussion of that? That obviously would have to come at least from the state, if not the federal level, to institute something like that.
So Vice Chair Trieger, I'll take the first comment or question first. So we're fortunate in Oregon to have two entities that liaison with the Oregon Health Authority with the local voice. The first is called JLT, the Joint Leadership Team. So it's senior people at the Public Health Division of OHA and senior health administrators and health officers. And it's a small group, and we meet for an hour, typically once a month, but sometimes more frequently. And they're fairly intense conversations, as you might imagine. A fair number of them are about funding formulas and, which counties get how much money. Is it based on population or disease burden? These are tough conversations to have. The other group, a much larger group, is the Conference of Local Health Officials. And that is a group of all 33 local health departments. There are many committees and subcommittees in that group, communicable disease, environmental health, et cetera. And that allows advocacy with the total voice of the local health department enterprise, and promoting it, but also liaisoning with the state. So we use those groups to work a great deal with the state. As you might imagine, we didn't agree with everything that they did during the pandemic, and we had some pretty intense conversations on closing everything down, and then when you decide to open it up, do you do it every 1 week or 2 weeks? We had a lot of intense conversations we didn't have complete agreement, but we had the venue to have the discussion. So we've used those pipes, so to speak, for conversations in the PPE space, and unfortunately, as I presented to you earlier, I had hoped the state would step up, and, you know, they have budget issues and political issues too, but they are not stepping up in the PPE space as far as we can tell, or in the critical clinical supply state as far as we can tell, so we need to do something. Your second comment or question, you know, the Defense Production Act, at the federal level, there was a lot of push to get the Defense Production Act, especially for testing, in addition to PPE. And some of us are active on the national stage too, and liaisoning with various groups. And I got to work with the White House's COVID response team quite a bit during the pandemic. And as a former federal employee and Navy officer, I and others pushed really hard that we need to do better with the Defense Production Act. Now, it's hard, right? I mean, this is not my area of expertise, but that was leveraged to make ventilators, if you recall. Ford Motor Company and General Motors were told, you're not going to make cars for a while, you're going to make ventilators in case we need them all, and they made thousands. But we didn't do it for other things. We didn't do it for PPE, we didn't do it for swabs, we didn't do it for laboratory reagents. That's a federal question, but your advocacy or combined advocacy across counties can be very helpful. I still think it's a challenge. We have a massive industrial might in this country, and our shortage of testing for months and months, our shortage of PPE was really a disgrace, really. We could have done better.
Thank you. Thank you for that response. My final comment for now is actually probably maybe more directed toward our administrator, and it's as much a comment as a question, which is we did a lot internally around policy to support our workforce through the pandemic, to keep county services going, to continue to deliver as much as we could other services in addition to the incredible yeoman's effort of public health in direct pandemic response. But also we were able to pivot quickly to allow more people to work from home, both to keep one another safe, but also to provide care support for family members when care supports and child care centers and elder care resources were shut down. So I think it's really important to acknowledge, one, that as a workforce of about 2,000 people strong, we were able to do that and really did a good job protecting workers and keeping services going. But I also know it's really changed the way we operate and is continuing to, and we're continuing to learn lessons and adapt around how we sort of hold on to the best parts of those policies and be a forward-thinking workplace. And also which ones really were so contextual that we need to sort of dial them back or change. So I don't know if you have a response to that now, but I think it's a really significant part of our pandemic response as an organization was our own internal policies to support our workforce.
Yeah, no question. I think up to about 2/3 of our workforce were set up within a matter of 7 to 12 days of, you know, I guess this was mid-March 2020. There was the sort of infamous meeting that I remember having with our assessment and taxation team where I was doing listening sessions, and I met in this room with our assessment and taxation at the end of the meeting. It was on March 10th. Just come back from the NACO Legislative Conference in DC, and there were just a couple cases of COVID in the country, and we had an employee at the end of that listening session said, "Are we thinking about remote work?" And I very, in the moment, said, you know, that's not something that as a government organization we're really set up to do. Well, a week later, fast forward, we had to figure out, just because that was our mindset at the time, was, well, we can't really do that for most of our employees. But then when that reality was forced on us, we had to figure that out. So within 7 to 12 days of the recognition that we were going to need to do things differently, we set up about 2/3 of our workforce remotely. And so, yes, we continue to pivot. And we said, you know, we negotiated agreements. I shouldn't say we had negotiated agreements. we establish policies to support our employees throughout that process, really leaning into the idea that let's meet our employees where they're at, that everyone is facing unprecedented challenges. We need to continue to deliver services to the community and be there where and how the community needs us to. But we also need to support our workforce, our employees and their families that are also struggling at this time. So that was a balancing act and something that, yes, we continue to adjust and evolve in capturing the benefits from that, while also recognizing that more and more our services demand our employees to have a physical presence.
Thank you.
Thank you, Vice Chair. Further comments? Commissioner Lovell.
Thank you, Chair. Yeah, thanks for the great presentation, Doctor. You have 8 great points, and you'd said before that you could probably go on and have many more. And I want to just maybe explore that just a little bit. You know, I've got people that have been asking me a lot of questions about what we did right and what we did wrong in the COVID pandemic, and I appreciate the fact that we've got 8 points here that are all about resupply and supply line, because you can't win a war without a supply line. So I appreciate the fact that we have that firmly established, but I'm also concerned about the elephant in the room question, and that's about the mental health suffrages that we had during COVID. You and I talked about that a number of months ago in the conference room. And, you know, there's still, I know, grandparents that haven't seen their grandkids yet because they didn't get the vaccine. And I know that there's a lot of fear mongering that we did and a lot of weaponization of people who weren't wearing their masks right versus the people who were wearing them below their nose or above their nose or whatever hill you wanted to die on. And my question is for the county is, in the next pandemic, although we're going to have our supplies ready, are we going to have our mental aptitude ready? What are we going to do as a county to limit the amount of fear and separation and divisions that we suffered as a community? Would we have anything in place for that?
Commissioner Lovell, I think it's a very good question. As you might imagine, we have vetted this internally, both in the public health space and then with our public information officer, Jason Davis, and then working with the state, their public information team, Jonathan Modow. You probably see him in the news pretty regularly. And from my point of view, I think there's one area where we could really improve quickly, and it is the outreach to the community early on and more persistent. We didn't start the public health radio show with KLCC for months. Now, we don't control KLCC. We don't control the other radio stations that we were on. And when we did start that, I was surprised, as you said, about the level of fear. You know, I'll never forget, I might get tearful on this one myself, but I'll never forget a call in on that first phone call. There was presumably an older woman, kind of tell by the quaver in her voice, who lived in the Florence area, wanted to know if she could safely walk on the beach. She would walk her dog every day. And if I remember my response, it's probably recorded somewhere, I said, not only can you walk on the beach, but I want to walk with you. You know, the risk outdoors is very, very, very low, but there were people wondering if they could do anything. And we needed to enter that space more quickly. And if this were to happen again, I and others would be out there right away saying, here's what we know, here's what we don't know, here's what we think we know, this is our recommendation to you. And again, you know, public health has very few laws. You know, we can't close schools and chain them and those sort of things. We make recommendations. But we would, at least my recommendation would be, we jump into that space much more quickly and deal with the uncertainty right up front.
That's great to know. And the other thing that you brought up too, just kind of an inference about the woman walking on the beach, was about people's rights to choose their health care and their HIPAA rights. A lot of people that have called me and voiced concerns about the things that we've done as a government, that we tended to violate their HIPAA rights and that kind of thing. And I'm wondering if going forward, are we going to allow people the options to have healthcare choices like we allow them in other arenas of politics? Because I know that the county put together a vaccine mandate for its employees, and that created a lot of pushback that people have called me on and wanted me to ask in this venue. So I'm asking us as a county health board, is that something that we're going to re-examine going forward in other pandemics?
I think we always will in all of these emergency events. I do think there's a challenge in bridging the clinical question and the legal question. Many of these questions are legal questions, and public health will make a recommendation based upon the available science and some extrapolation from past experiences. But ultimately, much of this is a legal decision. The labor issues that I mentioned about labor law and allowing people only to work 1,040 hours, vaccine mandates are a state statute in the occupational space. I can't remember the number, but 433.416, that's the ORS for vaccine mandates. So many of these are legal. And I'll add one more comment. I don't think we've exercised some of these relationships as well as we could in the inter-pandemic period. So for example, OSHA has a lot of power over the business, the occupational world. And in our experience in public health, we don't do a lot with OSHA when there's not a pandemic. And OSHA has a lot of power in this state and across the country, and we need to work with them more. So when bad things happen, we have a plan, a conversation, et cetera. And it was a real challenge for the entire first year. What are the OSHA rules in the business community? What are the rules coming down from the governor and the Oregon Health Authority? And how do the two work together? And that's a real opportunity for improvement as well.
Very good. You'd mentioned during our meeting, too, about our death rates in Lane County. What could you say to the public about that?
Oh, I wish I had those on the tip of my tongue.
706,
I did some time
you
ago.
said, yeah.
So we have comparators. We compare to counties that have similar demographics, similar population. Marion County is the county just below us in population, 360,000 or so. Clackamas is above us, about 460. So we compare quite a bit to those two counties, and our demographics are fairly similar, but not completely similar. Our death rate in Lane County was, about 60% less than Marion County. And we were proud of that in many ways because we think we worked really, really hard to keep the death rate low. But again, the demographics are not exactly the same. Marion County has a pretty significant Marshallese, Marshall Island population and some other minorities that we don't have, but we have some that they don't have. We also compared with counties outside of our state. And by and large, our death rate, I think Oregon as a whole was number 2 in the country for lowest death rate. So we did well, but it was not without some draconian rules that have impacts on businesses and schools and mental health, as you say. So it's a balance, a real challenging balance.
Yeah, and the death rate, you and I had talked about this about Farr's Law, that the death rate, he says, is the fact. Anything beyond that is inference. And I'm wondering if we're going to go forward on, well, we know a lot of facts now about COVID that we didn't know. And so I'm hoping that as a county, we go forward with most of those facts where some people have said it's science, that the facts we know, not political science, which is the things we followed. So I'm hoping we do that as a county. So thank you a lot for your expertise. I appreciate it.
Thank you, Commissioner. Thank you, Doctor. Commissioner Senega.
Yeah. Thanks, Dr. Ledke. I really appreciate that, where you're able to stay agile and move, because one of the things I was thinking was, I harken back to often is if you're going to fail, fail fast. Don't lower your head and keep going that way. And one of the things we did learn is get outside and breathe fresh air. And that, that I feel that could have been encouraged a lot sooner as well. Being, at the time I was a first responder, so there was a lot of gray area in those moments. And I think I'm also have my school board hat on. What kind of public outreach have we done to, say, the superintendents of the larger school districts and smaller school districts to see, we were hinging a lot of our decisions on what Lane County Health Authority said. And sometimes we get a quick decision, but the repercussion of that decision was very heavy for a school district. Have we reached out just to see what we did and the effect it had on the schools and the staff, for one?
Sheriff Flower, Commissioner Senega. So I will share two groups, and I really feel the need to invite Dr. Warren up here. But I'll share the first two. We had regular meetings with principals and superintendents, and they were virtual, and I can still see their faces in the Hollywood squares on our screens. And some of those were, I don't want to say contentious, but there were answers we didn't know, right? So these are challenging conversations. And they are sharing the impact on students as they see them and their student, staff, and faculty, and we are sharing the public health data that we have and the science that we know and what we don't know. And many times we came, I think, to really good decisions. So that was one. We had recurring meetings with these groups of school leaders. And then we did appoint a full-time person in public health to work with the schools. For much of the time, and Dr. Warren, I think you need to be up here, it was Kate Blair with, weekly calls with the schools. And that went on, for a couple years, for sure. Yeah. And schools we might think schools are all the same. They're not. They're as varied as a clinic is or, a business. There's variations in schools and their resources and abilities and such. So I'm going to pitch it to you. Other thoughts in the space for commissioners?
Thank you, Commissioner Seneca, for the question. I do think the one other piece that I thought I was really excited about during that pandemic, being able to support schools, was being able to provide data specific to the school district about new cases in their district. Early on, it was difficult to be able to talk about cases. As you remember, there was very little information that we could provide that would not be revealed too much in disclosure. So we had to be very careful. But once we reached a certain number of cases, we were able to provide then weekly to those school districts data specific to their school districts, so they could aid them in making very specific decisions regarding their population. So, I mean, I think the best thing that we could do was be able to support the school districts. We weren't making the decisions, but we were trying to be able to support them as best they could in making those decisions for themselves and communicating with the families in the school districts, which was absolutely very challenging, for sure. We have not, to my knowledge, done a specific follow-up, survey, an intentional data collection about those experiences, and whether that exists at the state level, I don't know, but I would be happy to look into that and consider that. We still have that same dedicated person still working with schools around other types of outbreaks and other communicable disease and vaccines. So we could certainly provide that information.
One more thing that I might add, just looking future forward, is that the policy level of this conversation, which is not necessarily as much a local policy conversation, because local public health was really not making rules during the pandemic. Local public health was interpreting rules that came from the state, and then was that liaison with local organizations to understand how those rules should be interpreted and implemented based on our best understanding. But there were lots of decisions made about whom to protect and how to protect those folks, potentially with others who were harmed by those decisions. And that's a reality. I mean, we know that with children, learning losses were significant in COVID. Mental health crises were significant. The impact of social media, suicide rates we have seen increase through that period of time, right? And yet our death rate was amongst the lowest in the country. And how are we making these choices from a policy perspective about how we protect people? How do we mitigate the risk related to the folks who may suffer as a result of those decisions? And those are all really important policy conversations for us to have, hopefully before the next one of these, so that we understand how the rules we are making are benefiting some and potentially harming others, and what are the implications of that. So I think it's a really great conversation to have here as well as at the state level.
Wow, thank you. And thank you for the question, Commissioner Seneca. You mentioned working with school districts, and you didn't just work with the larger districts like Fort Jay, but very admirably with the mid-sized districts like Springfield and Bethel, and with the smaller districts like Junction City and others equally well. And the smaller districts needed greater help in many cases than a district like Fort Jay with tremendous resources, comparatively so. So very well done. And that last regarding how the decisions were made, mitigating decisions to protect people and understanding that other people were going to be negatively affected or adversely affected in one way or another by those same decisions. It's a difficult business that we are in during such a time. And I'll state that you don't know what's going to happen. We flew to Ohio and went shopping at Kroger, and the next day went to Kroger to get some hamburger meat. There was no meat. And there was no toilet paper, and there was none of this stuff. So who could predict what happens? So the best thing we can do, Dr. Ludke, is what you're talking about. We extrapolate. We take the data that we have, what we do know, not just data, but statistics and actual anecdotal information, and try to predict what we can do in the future. And one of the things that we have done in Lane County is we've married emergency services with health. We've married emergency services with other social services in ways that never have been done before. And really in statewide leadership, we can attest to statewide leadership roles, marrying emergency services with other county services. Because in times of crisis, there's no line. Everything is blurred and we're all working together. Any further questions or comments from the Board of Commissioners? I see none. What a great after-action report, a good discussion. Much more could be said, and we could spend a lot of time talking about this. So I'll ask the panel, including you, Ms. Stenson, anything else you'd like to add before we adjourn the Board of Health? Well, thank you very much for the presentation this morning. At this point, I will adjourn the joint meeting of the Board of Health and Board of County Commissioners and reconvene the Board of Commissioners. And Ms. Smokerice, we'll move down our agenda to the next item, which is public comments. And thank you all for who are here for public comments this morning. I'll remind you, there'll be 3 minutes. You'll have 3 minutes once I call your name to the podium. And keep an eye on the clock on the wall in front of you to my left. It'll let you know as the 3 minutes tick down. I'll call the people in Harris Hall first. If you have written comments, please do not hesitate to submit them. And in Harris Hall this morning, we have first John Prophet, who will be followed by Rich Locke. Mr. Prophet, can you step to the mic, identify yourself, and your 3 minutes will begin.
My name is John Prophet. I'm sorry I have to keep coming, but this thing is so out of control, it's ridiculous. I went to LDM to file the appeal within 10 days. I have never done that before. Had an appointment with Jane Burgess and Amber Watson. Had my appeal stamped. They said, come back tomorrow because John Webster wanted to attend. So I did. I paid for the appeal the next day when they told me to come back. And then Jane Burgess, during the hearing last Wednesday, said, well, why didn't you pay for it the day before? They wanted to fine me for not paying for the appeal when they're the ones that pushed me out of the building and said, come back tomorrow. They had postponed the payment till the next day in the hearing to have me charge $780, which that amount is ridiculously wrong anyway, at $100 at most. But they made me wait. They are shady and underhanded down at the building department. I want to know what the relationship is with Mr. Miller and the hearing official, that Mr. Miller could feel free to tell him to stop the hearing and just fine me. He said that. It was the off-record section because we were producing documents, because nobody said, oh, I have to bring 5 sets. And Miller just says, just stop the hearing and just bill him. LMD is so out of control that they don't even try to hide it. They are bent on making me homeless for helping senior homeless people. Can you imagine that with St. Vinny's if they went after you because you help people? I can't believe you are okay with LDM taking my $2 million property. The new taxes came out. They said my house is worth $1.5 million, which might make you think I'm rich, but I'm not. I'm house poor. I live on Social Security. And the interesting thing about the $1.5 million is you can't even enter my house. How can some house be worth $1.5 million and you can't even walk in the door? There's some disconnect between the taxation department and land management. I know they're going to say, well, we don't talk. I've heard that before. Well, maybe they should. The answer is no longer to reinstate my permit. You need to grandfather my house in because they have shown and shown and shown how every time I comply, they're going to come up with more things.
Thank you, Mr.
I'm sorry to take too long. Thank you.
Rich Locke will be followed by Jerry Rosenmeyer.
Good morning, Commissioners. Thank you to the veterans that have also served for our country. I'd like to thank Commissioner Traeger last couple of weeks ago when she took a minute to review us with all the rich services that are provided in Lane County and throughout the Eugene area. But I'd like to say it's very expensive, and the amount of profit we see from the investment is small. Today I want to talk about the image of our community. First, many people, if you look at the amount of investment that we've made at the airport, many people travel in and out of Eugene. They're housing themselves in and around our city in hotels and such. They're traveling through our from the airport into our cities. I'd like to just draw everybody's attention to think about all those entrance points of Eugene and all over Lane County where you're entering cities. And look what we are, the image that they're being pummeled with at every entrance point of our city. How do you expect the financial growth and the popularity of our city here in Lane County to prosper when all we say when we enter these points is homelessness, garbage, tents, clothing everywhere? Every viewpoint that we see in our city is littered by this image. It's up to you folks here to figure out how we're going to humanitarianly shelter these people. It's the image is staggering that we are producing for them. I would like to again suggest that we put our minds together and figure out how we can have these encampments that are no barrier, that we can enforce the law, provide services to these people in 2 or 3 places around the county to where it's not this image busting. Besides the mental anguish that all of us that are living with it, I bet you a $10 bill that you folks haven't actually, I know David has, excuse me, I'm sorry, David has, gone out and got in the trenches and seen what happens. West 11th Corridor right now is a zombie apocalypse zone. All you see is people walking around aimlessly with their sleeping bags over their shoulders in the rain. I understand that we're not even, I'm sorry, I'm out of time. I understand that we're not even got enough support to open the Egan warming centers. What is going on here? Do we not care about those individuals?
Thank you, Mr. Locke. Next is Jerry Rosenmeyer. Please correct my pronunciation of the name if it's incorrect. And Mr. Rosenmeyer is the last person signed up in Harris Hall.
Jerry C. Rosenmeyer. A couple months ago, I presented comment at another Board of Health meeting where I suggested that the county conduct a census or an audit of healthcare staff in the county. Not just, well, because of burnout from COVID, but just to see how we're doing, just to see how our doctors and nurses' aides and all the ancillary staff rate, and if we're prepared for another pandemic or for the baby boomer, which I'm one, that's coming into needing more services. I didn't hear that mentioned in the health report, and I will again suggest that that would be something the county could pursue. At the time I mentioned it, a number of commissioners opined that they thought that would be a good idea and could be done. Today, I'd like to bring up just a quick related subject, and that is pharmacy and pharmacists. I'm sure you probably read that in the past week, pharmacists from a number of big chain pharmacies went on strike for a day or two, not for wages, but to protest staff shortages, unable to do their job. I'm sure you're probably also aware that Rite Aid has declared bankruptcy, and is closing a lot of stores around the country, including one here in Oregon, and they closed a regional distribution center. And I'm sure we all remember the crisis, I'll call it that, when Bi-Mart decided to go out of the pharmacy business, where my pharmacy, Rite Aid in Echo Hollow, is still recuperating from that. They still don't have enough staff. So the lines are very long, the backlogs for medicines are very long. If Rite Aid were to close a store, if it were to close Echo Hollow, not only would I be inconvenienced, and by the way, that would mean that there were absolutely no pharmacies within, say, Greg Evans's district in the city and the Active Bethel community neighborhood. So I'd be inconvenienced, but it would be that all over again. You know, anyway, backlogs and other pharmacies having to take up the slack, and they're also feeling the pinch. So I will add to my recommendation that if it's possible for some branch of Lane County to at least be thinking about the adequacy of our regional pharmacies, I think that would be a very good idea. Thank you.
Thank you, Mr. Rosemeyer. I'm going to ask for online. It's not just Greg Evans' neighborhood, it's my neighborhood, and I go to the Albertsons pharmacy right next door. So, Ms. Jones, we will ask for online testimony.
Thank you, Chair Farr. At this time, if you have signed up for public comment online, please raise your virtual hand and I will call on you. I will give you an option to be on camera as well. So we have 2 people signed up and 2 hands up. I will start with Heidi Ringus, followed by Chris Sherman. Heidi, I will unmute your microphone, and if you would let me know if you'd like to be on camera, I will change you from audio only. Heidi, would you like to be on camera? Heidi, I'm going to go to Chris Sherman. It sounds like we're just getting static feedback on you right now. I will come back to you after Chris. Chris Sherman, I'm going to unmute your microphone and ask if you would like to be on camera. Chris, you are muted at this moment. Chris, would you like to be on camera?
Sure. Yes.
Okay. One moment.
Yes.
You will get a request to change. You will get a request to change yourself to a panelist. One moment.
Okay.
And I see you there, and you need to unmute your camera, and we'll be able to see you.
Did I get it right?
We can't see you yet. Your camera is still muted, but we can hear you.
Okay. Okay. Maybe I don't know how to do that. So I'll just talk.
Would you like to just begin your testimony
I don't know how to
with
do it.
audio only, though? Okay. We'll just go with audio. You may begin your public
Oh, wait a minute. No, I think can I? Oh, there I did. I think I did it. Did I do it? Sure. Maybe I did it. Okay. Anyway, so my name is Chris. What? I'm sorry.
Your camera is still muted, so you can.
Oh, okay. Okay, I'll just talk. I'm sorry. I wanted to show a picture of my uncle, Steve, but that's okay. So my name is Chris Sherman. I'm from West Lane County. I want to thank the veterans also. My grandpa, Raymond Prefontaine, was a veteran and served in World War II. I wanted to add a couple of things too, like you were talking about the health. So I was hoping, as far as the health goes, smoke practices during the summer. I think we need more of a balance of that. And another part of health, Junction City, it'd be nice to have Cahoots expand to Junction City because they do such a great job. And the sports complex that's empty by West 11th, I was wondering if that could be used as for homeless. Okay, so the reason I'm really here is because of the charter change recommended by the Commissioners Review Board. I found out about 2 weeks ago, and I just had some concerns about it. My uncle's trail, the Priest Trail in Alton Baker Park, has a loop in the middle and in the far east section of the Willamette Natural Area. So I have concern what's going to happen to that with this change of the charter. I would like to ask for more time on this review and to make a plan for how Priest Trail will be protected and maintained going forward. If you go forward with this charter, I would like, let's see, I wrote some stuff down. So with my history of like with land, and you love things that are on the land, but it's harder and harder to protect them. So that's why I'm speaking out today, because I'm concerned about the future of my uncle's trail in the Willamette Natural Area. And Priest Trail, it attracts visitors, international visitors. It brings money to the community. It reflects our culture of the Tracktown USA. It was first chip trail in Eugene, designed by my uncle who graduated from the U of O and graduated in communications and architecture. So he used that to help design that trail. And his coach finished his dream for us in Alton Baker Park. I'm going to get emotional, but
thank you for your public comment. At this time, I will ask, Tanya, it looks like the staff computer got muted. Could you please unmute it quickly? At this time, I will go to Heidi Ringus. Heidi, would you like to be on camera? I'm not sure if it's just me who's not hearing you, Heidi, or if you're coming in with static to the board. If one of the board members could let me know if she's coming through clearly in the room, that would be helpful.
There is negative audio in the room on Heidi Ringus.
Okay. Heidi, we are not, I'm not sure if you're in a bad location or what's happening, but we are unable to hear anything but static on your end. I apologize for the confusion, and at this point, Chair Farr, since I can't seem to get audio, I'll return the meeting back to you.
Thank you, Ms. Jones, and we'll encourage Heidi Ringus to provide any written testimony. Now look around Harris Hall. Does anyone else in Harris Hall wish to provide testimony to the Board of County Commissioners this morning? See none, then we'll move along to remonstrances and/or other items from the Board of Commissioners, and I'll look to the board for comments. Vice Chair Trieger.
Thank you, Chair. Just in the interest of time, I just want to respond to Ms. Sherman. If you're still listening, the recommendation of the Charter Review Committee is to remove reference to Alton Baker Park from the charter because the county no longer owns that property. It is now City of Eugene property, and so any concerns or input or questions you have about use of that property and its impacts on the trails or other facilities there should be directed to the City of Eugene. Thank you.
Thank you, Vice Chair. Commissioner Lovall.
Yeah, just real briefly, also for the interest of time, for those that come to do public testimony, John Prophet, you said sorry to keep coming. Never be sorry to come and give your voice in public to the people that are supposed to serve you. So I just wanted to say that. Thanks for coming.
Thank you, Commissioner. Further comments? Then just a couple of things very quickly. I'd like to, Ms. Sherman and I have been in contact regarding East Alton Baker Park, and I believe there is nothing that is in the charter review that has any impact on the use of Priest trails. So we'll get clarification on that. Then, Ms. Mokrowski, I just want to have a question for you, and you no need to respond at this point in time, but it's regarding a couple of conversations I've had over the last several weeks regarding Lane County's participation in the homelessness response, particularly inside city limits. And there's some confusion as to what it is that Lane County does and what we don't do with both our general fund money and the millions and millions of dollars that are passed through Lane County, predominantly to nonprofits, but also to the city of Eugene, city of Springfield, et cetera. And I wonder if during your comments today you could talk a little bit about the things that the dollars that are either spent through general fund allocation or through pass-through money. If you could, later in this meeting, during your items, if you could just make a couple of comments regarding what we do at Lane County. Because sometimes people think that if they don't know that we do it, that we're not doing anything. I'd like to kind of give a response to that. Because we do have, through our Human Services Commission, through our Poverty and Homelessness Board, and through our Health and Human Services Department, we have many pass-through dollars that come through and are reallocated in the community. Is that something I can ask?
Certainly, and I'll just, I won't get into the details with you now, but to say that Lane County spends over $5 million in general fund resources annually on homelessness support, emergency shelter, coordinated service, and other areas. So I can give you a breakdown of that. That doesn't include, obviously, the state and federal dollars that pass through that we provide funding for, but despite one of the lowest permanent property tax rates of any county in the state, we spend over $5 million in general fund on those services. And so I've heard similar comments about, actually a comment that there were no general fund dollars spent by Lane County on homelessness supports, and that couldn't be further from the truth.
I'm going to point out that, and while Mr. Locke is in the room in particular, that a number of years ago, I think it was maybe 5 years ago, there was an issue with the homelessness or people hanging around downtown Eugene, and the city of Eugene was planning to open a day center on what is now our surface parking lot across the street. That day, it was a Friday, Mr. Mokrowski, you got together with staff, and some of that occurred in my office while I listened. I didn't participate. And by the end of that day, Friday, we'd opened what we later called Camp Lane on Lane County property. And we'd provided a place for people to actually erect their tents. It wasn't a particularly attractive place, shall we say, or comfortable place, but it was a place where people could go away from downtown. And by the end of that weekend, we were receiving thanks from business owners in particular. I don't know if we heard from the city of Eugene any thanks, but we had to provide an actual on Lane County property, a place for people to go. The net result of that was that we were able to provide greater services, even on an impromptu basis, to people who are congregated in a particular place. We were able to provide a breadth of I'll call it humanitarian services. Some of it was public health, some of it was food and sustenance, some of it was laundry services even, because people were located in a single place. And Mr. Locke has talked to us a couple of times about having people, a designated space where people can camp. Something that we have done, didn't work completely well at Camp Lane because of it became pretty crowded, and because there was some internal struggles that took place there. But something that we could think about for the future is how can we provide a place where we can congregate people in a more safe fashion than the unsanctioned camping that we see, and where we can actually provide services. Our FIT team, Forensic Intensive Treatment Team, goes out into the community, combing the sites, trying to lure people in to get the services that they need. It's difficult doing it that way. More doable when people are congregated in a particular place. So something to think about for the future is how do we provide services to people who need services, while at the same time alleviating some of the what has been noted as kind of what seems like a very unsafe situation in the unsanctioned camping that we see around town. I'm trying to be a little bit gracious as I say that.
Yeah, just one, because I know you're in remonstrance here, but one quick distinction I just want to make. Lane County's focus in the resources that we invest in this body of work is to navigate people out of homelessness and into housing. That is our goal. It has always been our focus, is to get people connected to services, temporary shelter if they need, but ultimately into stable housing. So that I know is, a difference of how resources are invested between cities and the county sometimes, but our focus is to navigate people off the streets and into a more permanent housing situation.
And Dr. Ludke mentioned the cash purchase of what is now the Navigation Center, the former Veterans Clinic on River Avenue, that is now being used. The county owns it, the county uses it, and it does provide that type of service where we're navigating people into what we hope is ultimately going to be permanent supportive housing or permanent housing. Well, thank you very much. Commissioner Buck, and then we'll move along on our agenda.
Thank you. I just wanted to add to your conversation there about that. In my experience working with those that are unsheltered, they don't necessarily do all that well in large congregate sites. And the city of Eugene does have 310 Garfield. I think it's 410 Garfield as well as those sites. And some of these are coming up with some funding shortfalls that are going to be significant in the next year. So I think it's a larger policy conversation that we can either individually talk to Human Services about, or maybe have a work session on. But I think data and experiences show us that large congregate sites are not necessarily in the best interests of the people we are trying to serve.
And that is a good conversation to have. Thank you, Commissioner Buck. Then we'll move down our agenda, move directly into the consent calendar. We have before us a consent calendar with a number of items on it. Every item on the consent calendar was considered by the Board of Commissioners to not require separate discussion. That'll be passed in a single motion. Any item that needed separate discussion would have been pulled from the consent calendar. If you go to our agenda online, click on View Items, it'll show you all of the information that was provided to the Board of Commissioners for consideration before allowing this to be on the consent calendar. And we'll move this forward with a single motion. Vice Chair Trieger.
Chair, I'll move approval of the consent calendar for Tuesday, November 7, 2023.
Moved by Vice Chair Trieger and seconded by Commissioner Buck. We have the November 7, 2023 consent calendar. Discussion to the motion. I'm seeing none. All those in favor, please say aye.
Aye.
Aye. Passes unanimously. Then we'll move down to item 7A, which is discussion on Lane County and Peace Health University District Hospital emergency closure. And we have an update. And back to our panel, we have Director Gray. Ms. Mokraski, I'll turn it over to you.
Thank you, Chair. The board had requested an update on significant change in the hospital care, access to the hospital system here in Lane County and the city of Eugene in particular. And so Ms. Gray is here to walk you through an update on the conversations that we've had with Peace Health and others in the community.
Thank you. So I'll just give a status update of where we are and where we think we're headed right now, and happy to come back and share more as things develop further. So just to make sure that everyone is on the same page about what it is we're talking about and what the changes are. In August of this year, Peace Health announced the impending closure of 3 services at their University District Hospital. So that includes the emergency department, which is slated to close on December 1st. I think it might be actually the 30th, so it will be officially closed on the 1st. The medical unit, which will be closing in early 2024, and then the acute rehabilitation unit, also slated within that same basic time frame, early 2024, to shut its doors. So that will end almost all hospital-level services on the University District campus, with the exception of the behavioral health unit. Peace Health did request a waiver from the Oregon Health Authority to be able to continue to operate a behavioral health inpatient unit on that site. Current Oregon state law does not allow a freestanding emergency department, and it does not allow a freestanding inpatient unit. The two have to be connected in some way. So the waiver was to allow the behavioral health unit to operate under the license of Riverbend Hospital and connected to that emergency department. And at this point, that waiver appears to be in place and with a number of requirements of Peace Health to be reporting data and information to the state. So my understanding at this point is that the waiver is a 6-month waiver, at which point Peace Health will need to reapply. The Peace Health's stated intent is to maintain inpatient behavioral health services on the site until an alternate option for inpatient care can be identified. So, looking at mitigation planning, the emergency department is that first piece that is closing and has taken a lot of attention for sure in terms of local conversations. So Peace Health is recognizing that that we need medical services in the area of University District Hospital and that we need extended hours. They are planning to move their urgent care, which is currently located on West 11th in the Fred Meyer parking lot. That is going to be moved to the University District campus, not on the same side of the street that has the emergency room, but on the other side of the street that has the medical offices associated with that campus. Though initially the hours may be the same as the current urgent care because there is a staffing requirement in order to increase those hours. The goal would be to extend the hours for that urgent care, and latest I heard was 8 a.m. to midnight as the goal, but somewhere in that area. I've heard 7 a.m., I've heard 11 p.m., but basically those hours of coverage with a recognition that we need those services. Peace Health, notably, is the only urgent care in our community that I am aware of that accepts all payers and walk-ins from any clinician. So that is, it is an important role that they play in our community and also a significant burden in terms of accepting a high proportion of individuals who are from payer varieties that do not pay the cost of care, so Medicaid, Medicare, uninsured. We are planning to open a walk-in clinic within the community health centers, and we are working on potential sites for where that walk-in clinic will be located. It won't be an urgent care at this point, licensed urgent care, so we would be accepting walk-ins for our patient population, and also it would be a way to get more new patients into our system so that we could see them for an initial new patient appointment at the walk-in clinic, then get them hooked up for their follow-up care at one of our other locations. So that work is underway. I hope to have a plan and a lease agreement to you in the next couple of months for that facility. We are also planning an expansion of our mobile program within our federally qualified health center, which is placing primary care providers on our 2-exam room mobile unit. And we are doing some outreach to South Lane County to start to build our presence there as we are building our health center, also looking at opportunities for street outreach and outreach to other areas that have high call volumes to EMS. So all of this in the context of what can we do to, through urgent care, through walk-in clinic, through mobile efforts, to reduce the pull on our emergency department for providing primary care services, which is a part of what our emergency departments in our community are doing and a part of what is overwhelming them at this time. We're working very closely with EMS on emergency department diversion efforts. So really trying to identify ways that EMS can, either through their 911 call center or once they arrive on scene and triage a situation is not an emergency, how do we divert folks away from the emergency room in those settings? So a number of conversations happening about innovation in this space. Peace Health is also convening work groups on the population that they call their friendly faces. So these are the folks who come to the emergency room more than 10 times a year, some of them hundreds of times a year, seeking services that are not primarily medical in nature. So how can we be providing alternative options and services? We have groups of a number of funders and community providers all coming together, trying to identify what we can do in terms of service stations or other opportunities to direct individuals to, particularly during off hours. We also are looking at what could a high-level urgent care look like in Eugene. This is the most difficult of all the things to achieve in our mitigation efforts, but we could, if we had a higher level urgent care that could hold people for 23 hours, had an on-site lab, and some advanced imaging, CT and ultrasound being the most important of the advanced imaging. Many people who think they might be sick but aren't sure could go to that facility instead of the emergency room. So there's a lot of rule out that happens in the emergency department just because it's the only place that has fast access to labs and imaging in order to decide if something's an emergency or not. So that is a service that would be beneficial to our community, continuing to engage with stakeholders about who might be interested in coming in. That would be an easier bar to achieve than, say, another hospital, and would be consistent with our efforts to transform more to a value-based care environment where we are providing the highest or the best care at the lowest level. So high quality care, but ideally not in the most expensive setting. For example, a hospital being a very expensive setting to rule out that someone's belly pain is gas, for example. And additional, and I mentioned additional discussions on opportunities to really lean into value-based care. So how can we use this as an opportunity to not just go back to doing things the way we've always done them in a very expensive healthcare environment and model, but maybe this becomes a catalyst for us to really think about transforming healthcare in our community at an accelerated pace. So I want to take just a moment to talk about the medical unit and acute rehab. There's been a lot less discussion on this within our community, but the medical unit is closing. This is, I believe, more than a 30-bed unit. I believe 35 licensed beds, but it's somewhere in that neighborhood. That has been very underutilized for quite some time at University District. All of the medical inpatient patients are being moved to Riverbend Hospital, and the mitigation plan there is that Peace Health has been closing about 50 of their inpatient beds every day because of lack of staffing at Riverbend. So they have a new group of nurses graduating from their nurse residency program in November. They plan to open potentially not all of those beds, but a proportion of those beds, which should add capacity at Riverbend to cover the 7 to 10 patients a day who have been at University District Medical Unit. Acute rehab, Peace Health is doing some renovations to move their current unit over to Riverbend Hospital, and they have a certificate of need that they have applied for the Oregon Health Authority to build in collaboration with another organization, a new acute rehab facility nearby to Riverbend Hospital. So they are awaiting OHA's determination on that certificate of need before they can move forward on that project. Behavioral health, lots of thoughts about this, and the fact that this inpatient unit is really necessary in our community, and it is not enough in our community. So we had an immediate urgency around the potential that the behavioral health unit would be forced to close because of the loss of the emergency department. That appears to be resolving for at least the next 6 months. The future of inpatient behavioral health in our community is, I think, best stated as evolving. That's the word I used here. We know that reimbursement rates for inpatient behavioral health disincentivize investment in our behavioral health system. So providers are expected to take losses in operating behavioral health facilities, and their margins are becoming tighter in other areas, which is making it more difficult to continue to invest in behavioral health as a business line that operates at a loss. So we also have a lack of everything in our behavioral health system, outpatient, residential resources, and that makes it much more difficult for people to transition from their inpatient stay into appropriate levels of care outside of the hospital, which is causing Peace Health to have to hold people for long periods of time, again, in a very expensive level of care and at a higher level of care that folks need, which is causing folks to back up in the ER who need inpatient behavioral health services. I will say that Peace Health is an engaged partner with us in envisioning what does the future look like, and we need to review the financial models in order to have private partners who really want to stay in there with us, and the governor's office is engaged with that. So I have spoken with them multiple times, as has Peace Health, as have a number of other stakeholders. And though we don't expect that the behavioral health unit is going to stay in the same location long term, we are looking at what the opportunities for partnership are for a new facility that would serve our community. So locally, we are in discussions with EMS around a number of potential programs for ED diversion. We are in discussion with our coordinated care organizations, or CCOs, our Medicaid providers, on other types of value-based reimbursement models that could help us with ED diversion efforts. And we're maintaining discussions with Peace Health regarding their facilities that are closing imminently, as well as the behavioral health unit. State discussions, we are talking with our state legislative delegation. Representative Nathanson has been extremely involved in this work and working on legislative concepts for both the short and the long session, and the governor's office has been very engaged with us. On the federal side, we have also been in touch with Senator Wyden and Merkley's offices around our needs at the federal level. And we are looking at how can we partner at a state and federal level, because it's both Medicare and Medicaid who are involved in reimbursing not enough for healthcare providers. And we really have to have both a state and a federal investment if we're going to make this system work. It can't all happen at the state level. We're also thinking about other types of concepts. For example, critical access hospitals. When rural hospitals started closing at really alarming rates in this country, the federal government created a critical access hospital designation, which provides higher reimbursement rates for hospitals that operate in rural areas. We are getting to the point with healthcare where critical access might look different. It might be a metro area that is serving a really underserved population and has unbelievably high percentages of Medicaid and Medicare patients. And could we get to a critical access hospital designation that could help support some of those safety net facilities in metro areas? Those are conversations that we need to be continuing to have, which is a federal level conversation. And of course, what about a new hospital? This has been brought up many times. I think that there is a lack of clear need for more inpatient beds in our community. Our ERs are very clearly overwhelmed. Our hospitals are overwhelmed, though have a number of closed beds because we can't staff them. So opening new facilities creates bricks and mortar without the other infrastructure in place, primarily healthcare workers, to come in and staff those hospital beds. And so really probably the better path for us to consider right now is how do we provide more services at a lower level of care so that we can meet the needs of our community and decompress our hospitals. But there are some potentially interested parties. Of course, We know from the building of Riverbend that land use is an important conversation when we look at the potential of building a hospital in the city limits of Eugene. And all of those are conversations that would have to happen outside of this setting. But we will partner with anyone who wishes to be a partner in this space and do whatever we can to support the development of services that within our community. Okay, so that's what I have right now. Questions, concerns, other things that I should come back with?
Thank you, Director Gray. A lot of information in a very short period of time, but anybody looking online, the slides that we saw on the screen are available online. Click on View Items, and those slides are available. I'll look to the board for questions or comments, and I'll mention one thing very, very quickly. And you talk about working with the state and the federal government, the higher hierarchical levels of government to make certain that we are receiving the services, the critical services. And you mentioned reimbursement rates for one thing. And you're fully aware that we have a legislative presence in the Capitol in Washington, D.C., and also in the state Capitol. And I know you're working closely with, for instance, our upcoming trip, which we call the United Front trip to Washington, D.C., where the Board of Commissioners participates with the cities of Eugene and Springfield and other jurisdictions to get our combined voices. Because every single jurisdiction that we travel on that United Front trip is affected by our ability to provide medical and behavioral health services. So with that, I'll look to the board and begin with Commissioner Buck.
Thank you, Chair. I have lots of questions. I'll try to narrow them down for you specifically. So the first question is, it kind of surrounds this concept of a high-level urgent care. And so this is somewhere in between a regular urgent care and the emergency room, fitting somewhere in there. And was this a concept you were thinking the county could provide, or are you hoping somebody else would come in? And the reason I ask that is because we know that other counties around the United States provide their own hospitals and run their own hospitals. This is more of an East Coast thing than a West Coast thing. And although I'm not necessarily saying we need to jump in to that boat, it does beg the question, because from an emergency management perspective, which I come with those rose-colored glasses naturally now, not having a hospital of some kind or an emergency room more specifically on the south side of the river is something that would baffle me from an emergency preparedness point of view. And I know that you mentioned that maybe there's not enough needs for the beds, although you mentioned there'll be more nurses coming on and they'll be able to open more beds. But it's the emergency rooms more specifically that is needed. So I find that the high-level urgent care is trying to bridge that divide. But unless it's open 24 hours a day, and if it is an emergency, they don't then have to go from one, maybe wait a little bit to see somebody, and then, oh my gosh, it's truly an emergency. Now we got to go send you to the emergency room, which isn't even a longer wait time if they had just gone to an emergency room. So that's kind of a whole bunch of questions and concepts in one that I'm hoping you might have some more information on.
Sure. So in terms of emergency preparedness, I would say that for almost all types of potential public health emergencies that we would be facing that would overwhelm hospitals, our staff will become overwhelmed faster than our facilities will. So before I would recommend investing in more bricks and mortar, I really believe that we need more investment in a healthcare workforce in order to staff those facilities. There is the potential major event of an earthquake that would cause bridges to become unpassable. If that were to occur, it is likely that we would have significant other infrastructure damage, probably to our local hospitals, both of them, or all of them. And the emergency planning at that point would be what field can we get people in with tents where we can land a helicopter and fly people out to hospitals that are in an area that has not been damaged. So my sense is that that the seismic question in an event of that magnitude, probably no matter what, we're going to be relying on hospitals that are outside of our immediate geographic area. And I think that we would probably do well to plan in that regard in terms of our emergency planning and how we set up field hospitals. And then there's the question around a high-level urgent care. I agree with you, 24-hour access is necessary. And really, it would operate similar to how, say, Cottage Grove Hospital operates, and in many ways similar to how University District has operated since Riverbend opened. UD has not treated heart attacks or strokes or done emergency surgery or handled emergency obstetric events or any of the other things that you would expect in a referral center since Riverbend opened. And I think that that a high-level urgent care largely can do all of those same things. If we have to finance it, and your other question was, would the county run that? Not with the resources that we have today. So if we were to pursue, for example, a special healthcare district, which is how in the state of Oregon, there are 10, I believe, special hospital districts that support hospitals within our state, primarily in rural areas. Those particular districts largely have a board that contracts out the running of the hospital to a private entity. So we don't, in the state of Oregon, I don't believe we have any hospitals that are truly county run. I would have to check with Harney County. But this is the model that's typically applied in Oregon. Certainly we could look at funding mechanisms through some sort of a district if it seemed that was necessary because we were unable to recruit the private sector in to perform some of these functions for us. My preference would be to try to recruit the private sector in to perform these functions for us rather than going down that route. But that could be something that you all could instruct me to look at some point, and I would be happy to do so.
Thank you. Appreciate that.
Thank you for the questions, Commissioner, and thank you for swift answers. You know, it's something that does affect all of us, and I'll talk more when briefly when it's my turn. But looking for further comments, questions. Vice Chair Trigger.
Thank you, Chair. Thank you for the presentation. You and I have been in a lot of contact about this. So, but as I was watching it, I just had a big picture thought, which is, and I keep in mind our administrator always saying, never let a good crisis go to waste. Might there be opportunity, is there any discussion amongst the partners you're talking to about this also being an opportunity for some really creative and innovative joint programming, given the incredible lack we have of residential or long-term treatment beds for substance use disorder and other addiction services? Is there maybe any opportunity to start co-locating? Because we know we see people, their entry is into an emergency or urgent care, but what they really need is longer-term treatment. And I know there's some, hospital social workers and case coordination and case management to do warm handoffs, but is there any, do you see this potentially as any opportunity for sort of reimagining what those kind of co-located services could look like?
What I would say is that the best modeling we have of that right now is really in thinking about the stabilization center and what needs the stabilization center serves in the long term, what services are co-located on the same sites. Largely, the emergency room struggles because of the lack of community resources and the lack of resources that are open after hours. And that that makes it really difficult to do warm handoffs and provide care for folks in the way that we would like. So yes, we are looking at what might be co-located and recognizing that the underinvestment in behavioral health services in particular has happened for so many decades that digging out of this is going to be really hard and really, really expensive. And each service that we add is a help, and at this point, it's going to feel like a drop in the ocean. So, that is what we face at this moment.
Thank you, Vice Chair. Further questions or comments? They've been in the Uni District for so long. 2 of our 3 children were born right there. It's with great poignancy that we see a diminishment of services in that area. At the Mental Health Summit 2 weeks ago, there was a presentation regarding services and emergency room services in particular, as well as behavioral health services. And I think I share a lot of confidence that Peace Health is a great community partner. Peace Health has been for many, many, many years, and they're not going to abandon that. And I really appreciate your personal attention to the details on that, Director Gray, and the work that you're bringing forward to make sure that our our concerns are alleviated as well as they can be. And really, I believe that, once again, Peace Health will remain a strong, powerful community partner throughout my lifetime, most certainly. So thank you for that. Without further comments or questions, Director Gray, anything you'd like to add?
I don't think so.
Very well. Okay, then we'll move along on the agenda. Thank you very much. And once again, those very informative slides are available online. So, Mr. Mokryski, we'll move down the agenda to item 8A, which is Public Works. It's a first reading and setting of the public hearing on Order 23-110708 in the matter of setting a public hearing for the vacation of a portion of 7th Avenue, a public road located in Section 4, Township 18 South, Range 12, west of Willamette Median in Lane County, Oregon, 18-12-0411. And we have a date for a public hearing. And Mr. Blomé, thank you for being patient and listening to what has been a pretty informative and really interesting Board of County Commissioners meeting. So I will directly turn it over to you, to Mr. Blomé.
Thank you, Chair Farr. Good morning, Commissioners. I'm here this morning to request a public hearing date be set for the matter of the vacation of a portion of 7th Avenue, an unimproved public road, which is located in Section 4 of Township 18 South, Range 12 south of the Willamette Meridian. The Surveyor's Office has received a petition to vacate signed by 2 out of 3 total landowners that abut the portion of road proposed to be vacated. Since the petition is signed by less than 100% of the abutting landowners, a public hearing is required to allow for the board to consider public testimony prior to approving or denying the vacation request. I would like to request the board to approve a public hearing date of January 9th, 2024 at 1:30 p.m. time certain. The date we are selecting will allow the Surveyor's Office ample time to notify the public of the public hearing date in accordance with ORS 368 requirements. A complete report of the road will be presented to the board during the public hearing. At this time, I'll turn this matter over to you. I'll be happy to answer any questions you may have.
Thank you, Mr. Blomé. Then I'll look to the board for questions or comments regarding an upcoming vacation. Sounds great. Where are we going again? I see none. Then Vice Chair Trieger.
Chair, I'll move approval of a first reading and setting of a public hearing on Order 23-11-07-08 in the matter of setting a public hearing for the vacation of a portion of 7th Avenue, a public road located in Section 4, Township 18 South, Range 12, west of the Willamette Meridian in Lane County, Oregon, 18-12-04-11. That public hearing and first reading is to be held January 9th, 2024, 1:30 p.m. time certain.
I'll second.
Moved by Vice Chair Trieger and seconded by Commissioner Lovall. The first reading and setting of the public hearing on 23-11-07-08. Discussion to the motion. I'll note that Trevor Ross is with us today. Trevor, good to see you again. We meet every now and then. It's good to see you in this perspective. Any discussion to the motion? I'm seeing none. Then I'll call for the vote. All those in favor, please say aye.
Aye.
Passes unanimously. Thank you once again for your patience, but I hope it was entertaining and full of information for you.
It was very informative. Thank you.
Good to see you. So we'll move down our agenda into county administration announcements. Mr. Mokrycki.
Chair, I just had a couple things. I was going to give an update on elections. Today is election day for around 38,000 voters in the city of Eugene, Ward 7, Siuslaw School District, Pleasant Hill and Goshen Rural Fire Districts, and River Road Parks and Rec District. The results will be posted by 8 p.m. and then again at 11 p.m. The ballot returns dashboard is up to date, and Lane County election site will have all the information that you need at lanecountyor.gov/elections. And then, Chair, I just wanted to respond with some additional information to the question that you asked. Again, I think we have some work to do to adequately inform our various stakeholders, in particular our partners in this work, and I would say the cities of Eugene and Springfield in particular around the role and investments that Lane County is making in the very complex set of services that we provide to navigate people out of an unhoused condition on the street into services, temporary shelter if needed, and ultimately into housing. We invest over $5 million in general fund resources. So again, in addition to the state and federal dollars that we leverage, over $5 million in general fund resources are invested in our human services division, in the Dusk to Dawn emergency shelter program with St. Vincent de Paul's, in the 75-bed shelter navigation center on Hunter River Avenue, and in our homelessness systems transformation. Some of these things were investments that were called out as part of the TAC report from 2018 that was a Lane County and City of Eugene partnership investment that Lane County continues to invest in the recommendations brought forward as part of that. In addition, we have $1.6 million set aside for the Shelter Navigation Center Reserve, and over $1.6 million in one-time investments in behavioral health services. Of course, nearly $10 million has been set aside for a behavioral health stabilization center. And then this does not include all of the investments in permanent supportive housing, the multi-million dollars. So I have asked for a general accounting of all of that over the course of the past decade, simply because we all need to be talking about accurate information about the investments that are being made, the different types of priorities and strategies that Lane County is focused on. So we'll share more of that as it is available. That's all I have.
Great, thank you. I'll take over for a moment as the chair had to step out. Thank you for that and for bringing it back to us. I don't know, unless one of my colleagues wants to name an amount of time in which you bring that back, that it's necessarily needs to be tied to a timeline. I would like to request, when information is brought back to us about our investments, as you in those programs you mentioned, that we might also have some sense of the geographic application of those dollars, so we can get a picture of the county and where we're making those investments relative to population size and so on. I think that would be a good piece of information that could accompany that information. Thank you.
Yes.
Anything else from you today?
That's it. Thanks.
Okay. Moving on to item 10, Commissioner's Business. Are there any announcements from the board? Seeing none. Any future board assignment requests? No. All right. Then, reviewing assignments, Mr. Mokrycki.
Just that request, I just want to make sure that that's something I offered to bring forward that commissioners are, I sort of heard that turned into an assignment, so I want to make sure that there's support for that to bring forward a sort of an accounting or a breakdown. I asked for our staff to put together like a 10-year look at both the annual investments in various general fund investments in various homelessness services, as well as one-time investments, both emergency shelter, housing, mental health supports, and other things. And then I heard the request that that be broken out by jurisdiction, where the funding is invested for services. So I just think I'm seeing head nods for
Yeah.
that to come back with.
Great. Thank you. Then we have no need for executive session today. Any other business? Seeing none, we will be recessed until tomorrow, when we will have a 9 a.m. meeting here in Harris Hall with a hybrid participation option. It will be a presentation from county administration and a work session on our Charter Review Committee's recommendations. So with that, we are recessed till 9 a.m. tomorrow.